So I believe I am sharing my screen. Can you let me know if you can see it? Okay.
We can.
Perfect. Thank you. Okay. So we're going to go through an overview of the changes that we are proposing for the alternative payment model for calendar year 2023. This model will be submitted again as a whole unit. So this will be reviewed by CMS as a whole, not as individual components. It's also really important for us to be clear that this is a proposal. Our plan is to submit this model in early August. Even though the final deadline for submissions is not until the end of September, we're hoping to use the additional 60 or so days to get an initial sense of CMS's feedback. So if there is a need to pull the model, make some changes, and resubmit it, we will still have sufficient time to do that before the final deadline for submission. It is required that any model that is not standard fee for service has approval from CMS prior to implementation. So if we do not have approval for the model by December 31st of this year, the only thing we have authorization to operate in January in 2023 is essentially fee for service. So we are on a really tight timeline here. It's certainly not the timeline we want to be on. I'm sure it's not the timeline you want to be on. It was just a lot of contingencies due to the 1115 waiver not being signed until June 28th, and there were a lot of contingencies here in this. So that's kind of what our basic timeline is. And there is a little included in the overview. You can see a little bit of that listed here, so you can get a sense of kind of the timeline that we're on and trying to effectuate the model by January 1st. So the various components of this model, as we have let folks know, we are planning to increase the minimum threshold for payment from 90% to 96%. Along with that increase, we are going to request from CMS some additional spending authority for the state, which would essentially, for those organizations that may not meet the minimum threshold for payment and for funds that would potentially need to be recouped from agencies, we would like to be able to redistribute those funds to agencies that have served over what was anticipated. So this is not new money. So if everybody gets to 96% or above, there would not be funds to redistribute. So this would only be in the event that there were funds that needed to be recouped. And we have not determined how that redistribution would take place. I think that's part of what we're gonna work with the network on figuring out. Although I will say that we anticipate that it would be some combination of both caseload and service utilization would be how we would make that determination for any redistribution of funds over what was agreed upon at the start of the year. But again, this is something that we feel like we have some time to work with agencies to kind of really figure out what that methodology would be. We have not made any decisions there, but just wanted to make clear that this is not new money. Carrie, you can hand up.
When you say that, excuse me, when you said that you have time to figure that out, the timeline didn't look like there was time to figure that out. And can you just speak a little bit more to that? And I'm going to throw it out there, and it's the same conversation we had last week. The system has been choked for the last 14 years with insufficient funding to support caseload and cost of living. there isn't wiggle room in people's budgets to have money moved. And so that feels like a very scary conversation to me, and wondering how that's going to be handled.
So this would be funds that were recouped from an agency that did not meet the minimum thresholds for payment. So it is not different than the situation that we have now, except for the fact that right now we don't have really spending authority from CMS for the match portion of this to do any type of redistribution of funds. So this is not different than it would be an agency facing a recoupment today.
But understand.
Go ahead.
No, I guess I should just let it go. I mean, the reality is the reason that agencies aren't hitting it is because the funding hasn't been sufficient to allow for it. But I guess if I don't want to be the only DA who's feeling this position, I guess I would love to have other people chime in.
I think Heidi and then Bill had hands up. I think that was the order.
Yeah, thanks. No, so a couple things. I mean, certainly I absolutely agree with Carrie, and certainly this 8% increase we got this year is a step towards allowing us to recruit staff and retain staff. It's nowhere near what we need to get folks from market. So I mean, that is, I think, important. But my question was more around when an agency is not hitting their target due to vacancies. So just what we're talking about. And so therefore they have a reduction. Is that a base reduction? So therefore next year when they hire, they would actually have to pull that recruitment because they no longer even have the funds. So I'm just trying to understand, like, how would you operationalize this as a one-time or an ongoing reallocation?
Shannon, do you want to? You're muted. You're still muted.
This is the one-time recoupment of funds because an agency might not have met their threshold. This, Nicole, correct me if I'm wrong, this is not a valuation process where we say you underserved, you overserved, so we're going to move the money around. This is you underserved, but this agency over here more than met their targets. They overserved, so they should get a little bit of money. And I believe this was a request as part of one of your requests in your memo, that if somebody underserved and you recouped money, would you be willing to then give that money to another agency? But I envision this as one-time funding. This is not a revaluation of your case rates. Nicole, did I get that right?
That is also how I understand it too. And the other piece that I would add is that while payment reform and this process has been designed to provide agencies with some stability and flexibility in payment, I just want to also remind you that this is still a model that requires organizations to serve Vermonters. So that is ultimately, while you are paid prospectively in a lump sum payment, those payments are for serving Vermonters. So it is not so different from fee for service in the sense that you would be able to pull down funds for services that were not provided. So it's just not how the model operates right now. Okay, Bill.
Yeah, you answered part of my question, I guess, and some of us sent in questions prior to this meeting, so I'm not sure. I think I might be asking a question that you're going to address later. But how would it actually work as far as if an agency was under and another agency was over? So how much would you have to be over in order to receive someone else's money? Is there a threshold that's being identified? Like you have to be just one person over and you get the $1,000 per member per month for you, or is it got to be 1% over before you start getting monies allocated to you? Anyway, it goes back to Heidi's question as far as the operationalization of of what you're talking about is that for the one-time redistribution of how that's going to work. It'd be very helpful to have that clearly identified on what the, I guess the opportunity, if you will, if you're over providing, and what that might mean for you to, if others are under providing.
I don't think that there's a way for us to answer that question specifically or directly. I think what we would need to do is to essentially develop some criteria, because the situation would be really fluid. And so I think it wouldn't make sense for us to say, to make exact prescriptions right now. I think what we would need to work on is criteria for how to make decisions where there are funds for redistribution, and how we would go about that is at least the way I envision it. But I think this would be the conversation that we would need to have.
And the intent would be, this would not start, so it's effective January, but the first reconciliation doesn't happen until calendar 2024, and all of the paybacks, if there were any, would occur before the end of June of 2020, calendar 2024. Is that correct?
Those are good base dates. I think, as a good example, right now, we're currently still working with agencies on reconciliations for calendar year 2021. There's extenuating circumstances always with timely filing claims. So I think our plan and how we kind of approach this is work with agencies to kind of make sure that they feel that their claims have all been submitted before we do anything. And so we certainly don't want to make a decision prior to actually having all the information. So I don't think we can say what that exact timeline is, because it really depends on the agency's needs. But I would say, generally speaking, it's you would anticipate that around July 1 of 2024. I think you're on the right track.
So thank you. That's helpful. Specifically, when the reconciliation, we've been doing this since the start of this, I believe, where we do the reconciliation. Maybe we were held harmless during COVID, but next spring, when we do the reconciliation for this current calendar year we're in, are you proposing, will there be a one-time redistribution of any agency who doesn't meet the 90% threshold that's currently in place for this calendar year? Or how does it work currently in the recoupment? Do you guys at the state just keep it, or does it get redistributed to the designated agencies? I'm not clear on the current environment that we're working under. If there was any, shortfall from an agency not meeting their targets, how does that get redistributed, or does the state just take it back?
So the recoupment would be based on whatever was the minimum threshold that was approved by CMS for the year in question, right? So for this current calendar year, that is 90%. For calendar year 2023, we anticipate that to be 96%. So the recoupment would be based on whatever has been approved by CMS for that calendar year. And the state, I think that you're hitting on exactly the issue. The state doesn't want to keep recouped funds. We want to make sure that it gets out to agencies and it gets into the system, and that we want to try to use any funds that were recouped to distribute to agencies that served greater than their forecasted caseload or service utilization, or however we figured out the criteria.
But I think, Nicole, he's asking right now, if we take back funds from fiscal year 21, we really don't have a mechanism right now to redistribute those funds.
That's right, Sharon. Thank you.
That's the reality of it. It doesn't mean that they won't go back into the system. It just means we don't have a current mechanism to do that through the case rate.
Thank you.
I think you have a new hand.
Yeah, sorry, I was reading it. I was reading ahead a little bit, so I may have missed the answer, and I apologize to the group. So if there's a recoupment for FY21, is that what so there is going to be a recoupment for FY21, an actual recoupment, not just a looking at the, okay, so, and in which year would we be booking that? Would that be in
Shannon,
FY 22? Like,
Well, I'm
this
guessing
June?
that your 21 books are closed and probably nobody booked a payback for that.
Well, it
Actually, I
was a
know one
20
agency did.
FY 2020, well, 20, I think we really do need to hammer that out because 2021 doesn't finish until midway through FY 22.
Right,
And you
okay.
have the opportunity from July through December to actually catch up, right? So you really don't have a liability at all until December, theoretically, right? Because theoretically, you could just make it all up in December. So you really don't have any liability until December of 21, which is during FY 22. That is your FY 22. Does that make sense?
Yeah. You're correct, Heidi. That's right. That's absolutely right. Yep.
so
I would not. Yeah.
Oh, sorry, go ahead.
Sorry.
Well,
But I wanna kind of pause for a second, and I wanna check in with the group and to see, because I know this 90% and this 96% is a point of a lot of stress, but I want to check in, being that it's 3:30, to see, do we want to move on and kind of get through the rest, or do we want to stay here and continue to talk about this part? We're certainly flexible to whatever you need. I just am conscious of the time, and I want to make sure that we get through everything you need us to get through.
so Nicole, this is Bill. We can move on, but I guess I don't know where this plays out in negotiations with the provider agreement versus what you have to submit, but it seems like there might be some other elements, like a full reconciliation of your kids might be down slightly and your adults are over. So reconciling the whole of payment reform, not by the cohorts themselves. Or is there an opportunity to again transition not to 96%, but say 93 or 94%, again, on-ramp that the CFOs were talking about. So I think there's some things that need to get fully, fleshed out on those things. I just don't know where that forum is. But, and I don't even know if it's a possibility to talk about those things and other things that other folks might have ideas on.
Okay. Sorry, Laura. Go ahead.
I mean, I think Nicole and Shannon, would that be part of the negotiating around if your child case rate is at 115 and your adult case rate was at 91? Those probably numbers don't work, but if you put them together, you hit your 96% versus, is that something we can negotiate as we talk about how we're going to operationalize this? I think, Bill, that's what you're asking.
Yeah, I think we can talk about it. I will tell you, and I think you can check the data to see this. You would see that the place where the services aren't taking place is in the children's programs. And so it is problematic, I think, from a service standard for the state, for us to allow the service of adults to offset underserving of the children and youth. So it's something that we can talk about, but I will just say offhand, it's not as simple as just looking at it as a full cohort.
Okay, thank you. That's helpful to hear from you on that.
And I'm also not sure what the actual language in the preprint says. I would have to look at that. I'm not sure that it allows for that either.
Right now, it does not. Yeah, right now, these are two separate case rates, and there's no, but I was actually thinking about moving forward, if that's what, but right now,
I think
that's
the goal here is, again, the on-ramp as we move, I guess, eventually to 100% of how can we mitigate that and the impact, because each of our areas might have a more intensive need in the adults versus kids from year to year. So to be able to have that flexibility to meet the need of the community within payment reform was, I thought, the main basis to serve the Vermonters that need it. So it just seems like we may be unfairly penalized if we are overperforming in one area and underperforming in another. And that should be part of the reconciliation process as you consider the full mechanism that you're implementing within, your waiver negotiations and how it impacts us. So I'll stop now. Thanks.
Yeah, and I think to your point, Bill, I think we talked about this a little bit yesterday. These negotiations with CMS are not, they're difficult. And this is not just the state goes in and tells the CMS what we want and they say yes. Like, this is a process. And I think the emergency services global payment is a pretty significant ask from, we anticipate that to be a difficult conversation. So I think were they to decline to allow us to move those program dollars, that might be a time for us to revisit whether or not the 90 to 96% move still made sense in that environment. But in the current environment that we have, looking at the model as a whole, we are trying to balance the flexibility and the kind of accountability on the agency side. So this is a little bit of a balance, and it will be a negotiation. But I think depending on the feedback that we get from CMS, though, I think that's the time for us to kind of think through where we might make tweaks and changes to mitigate kind of all of those pieces. Okay, I am going to try to move on now. So I'm going to skip over the next one, which is the talk about the value-based payment percentage increasing from 1% to 2%, because I'll let that be a part of the conversation with Steve and Eva about the performance measures, and I'll move us. I'm going to move us right down to the emergency services global payment, and then I'll walk us through the flexible payment as well, and then I'll transition this to Steve and Eva. And sorry for skipping around a little bit. Okay. So here is what we have. I'm going to make it a little bit bigger. Is that clear and visible to folks? I can make it bigger again. I'm trying to keep as much. Maybe I'm going to hide a couple of agencies just to make sure I can keep everything on screen. Is that visible to folks?
Yeah.
Thank you.
Everyone can expand too if they want.
Okay. So here is essentially how this methodology is working. I think the bottom line that is important to say up front is that agencies are neither losing nor gaining any funds through this process for calendar year 2022 or 2023. That this is methodology we have here is largely designed to be the least disruptive to agencies, because again, we recognize how quickly these decisions needed to come due to the timing and the negotiation of the 1115 waiver. And so our goal here with this is to really try to retain agencies and allow them to remain whole to their current funding levels. So that is the goal and kind of the bottom line takeaway to make sure we think through. So essentially what we did was we looked at the investments that we were going to be required by CMS to migrate into program for calendar year 2023. That number was $12.7 million across the network, and it included a variety of things: emergency services, adult capacity, various types of investments. It does not include things like respite or youth in transition or any of the investments that were never required to migrate over into program. It's just that $12.7 million for those investments that we had informed you back in October or November of last year were going to be required. And, we can certainly, Shannon has sent your individual agencies what exactly those investments were. We're happy to send them again if you would like them. But so this is that $12.7 million that was scheduled to move over is really the numbers that we're working with here. But we also looked as kind of a proof of concept at how much in fee for service were agencies billing back in 2019 when we moved these dollars over into the case rate for underpayment reform. We looked at that number back from 2018, that what they were, and to what they are now, and they are really pretty consistent. These dollars are not here, they're not moving. They're dollars that were moved into your case rate in 2019. They're dollars that are staying in your case rate for 2023, 2022, and 23. This is really just here for us to get a sense of what are agencies billing right now for these low threshold emergency services. What were they billing before? Just to get a general sense of level of consistency.
Hey, Nicole.
Sorry, you have a hand up.
Oh, well, yeah, I just pointed clarification because I think you clarified for me last time. It's not what we were actually billing in 2019. It was on our exhibit as crisis allocation in 2019, right?
Thank you. Yes, I made that same mistake the other day. Yes, thank you for that clarification. It was perfect too. Thank you. Yes. So, but we looked now to see what folks were billing, and that's what it was. And right now, that's what you're billing is right around those dollars there. But so I'm going to move on to the emergency services global payment. So essentially, we're going to be required to transition the $12.7 million. That we anticipated all of the CMS to require that full transition. We were able to retain approximately $6 million for global commitment investments of that 12.7. So that 6.7 still needs to transition into programs. And our plan is to use this emergency services global payment to transition it into program dollars. So we have the $6.7 million to distribute to organizations. And you need to think of this kind of as a methodology, although there are decision points here that I sent out in an email earlier and we'll talk through, and I will certainly revisit again. But essentially, for the sake of this right now, what we've used is county census. So we looked at the total population of Vermont and essentially what was the census, the county census, that we could attribute to each designated agency. And you can see those numbers there. This is, of course, our first decision point, which is both how should we attribute lives to designated agencies? Should it be through county census? Should it be through catchment area census? What is the data source for that? And also importantly, is it obtainable? And then so we're happy to kind of take your feedback there, but right now we're using county census. We also are looking at we're looking at the Medicaid penetration rate. So for this methodology, what we're looking at is the statewide penetration rate. This is another decision point for us though. Do we want to use a statewide penetration rate? Do we want to use a catchment area penetration rate? What is the data source that we're going to use? But essentially what we do is we take whatever is that census count for that designated agency, and then we figure out, like in this methodology, Clara Martin Center has approximately 5,500. We would anticipate Medicaid beneficiaries living in that area, and that times the number of, distributing the $6.7 million comes to $310,000. So in this example, Clara Martin Center would essentially get an emergency services global payment of $310,000. That would not require service utilization hits. So part of what we're recognizing is that, especially for these low threshold emergency services, we really want the focus of the clinicians to be on the crisis and that initial emergency assessment, evaluation, support, referral, those things that happen in the moment, but not to be focused on the collection of insurance information. Right now, we recognize you're billing H2011, but we also know that there are probably Medicaid beneficiaries that you're providing that service to, but just due to the nature of service delivery, you're not able to bill down that code. And we want to be able to recognize that is appropriate, like you are making an appropriate choice there by focusing your time and energy on, dealing with that initial crisis. But it's also important to say this payment is not intended to cover your entire emergency services program. So anything like a follow-up, therapeutic, crisis bed, at that point in time, I think we can anticipate that you would be able to collect insurance information and bill that. And so those funding for that part of emergency services would still be pulled down through your case rate. So those dollars would still stay in there. They would still qualify to bring down a case rate count. H2011 would no longer be a case rate qualifying service. It would move into the support code, so it would still be valued as a part of your service delivery. But it on its own, if H2011 is the only service that you provide in the month, it would not be able to pull down a case rate. And that is really just due to the fact that we can't pay you for the same services twice. It would be a duplication of payment if we gave you a global payment to cover the H2011 services to Medicaid beneficiaries and then allowed you to pull down a case rate if that is the only qualifying service that individual receives in a month. So that's essentially how we work that portion out. I'm going to move right into the flexible funds, and then I'll pause after I get through that part. So it's really, I think, important to say that the flexible funds right now, this is not a methodology. Essentially, what we've done is we've looked at how much were your investments in 2022, how much are we going to be able to deliver to you in this very investment-like manner in 2023, and what is the difference? And so for Clara Martin Center, that difference is $734,000. We don't quite have enough money to redistribute flexible payments to keep everything in this investment-like manner. So we had to kind of give everybody a little trim across the board. So you can see here, there's a difference in payments of, if we're only able to give Clara Martin Center the $600,000, that means that there's still $137,000 left over. Those funds wouldn't leave Clara Martin Center, they would just move into Clara Martin Center's case rate. And we would work with agencies to figure out whether or how to distribute that through the children and or adult case rate. That is certainly another kind of decision point for us to work through once we get to those final numbers. So it is also important to say that the distribution for these flexible funds, we are only proposing this methodology for calendar year 2023 to keep agencies whole to their current investments. By 2024, we would need to be able to distribute these funds based on a methodology that is data informed. We don't need to have a decision on that in order to make this submission to CMS. It is not, this flexible payment is not a part of that overall submission. So we plan on kind of pausing on figuring out the mechanism for that 2024 redistribution to work with agencies through October and November and figure out, what data would inform the distribution of the flexible funds for calendar year 2024. So that way we could have any type of data collection in place by the start of January of 2023. So that's essentially how this works. Shannon, I probably missed some important things. So can you fill in anything that I missed through that before I open the questions?
I think you got everything, Nicole. Does anybody have questions?
Hi. There are not questions, and maybe they're not questions because at this point we've done a couple of, I think 8 of 10 agency one-on-one. So we've been able to kind of work through this with agencies already. So that might be why we're not getting too many questions. For NCSF, I think, and Memorial, we have meetings with you the end of this week. So we'll actually spend some more time kind of going through the specifics for your agencies when we get there. But if there aren't more questions about the emergency service global payment and the flexible funds, then I'll move us into the performance measures.
Can I just ask one quick question, Nicole? What's the process for making that determination around census versus, doing the state penetration rate versus the county or catchment area? I mean, state seems really broad to me, but that's just my gut.
Yeah, I think what we're, I'm going to come out of the share screen. I can always go back in. I think that we realize that, for this probably feels a little bit like a zero-sum game. Like, there's only so many Vermonters, and, like, that's the number of people we had to distribute. So I really think we're looking to the network to provide feedback on there. If the network doesn't have if the network doesn't have a recommendation, I think the state would kind of, we would need to move to using something. It would probably be the census. And I think we would probably stick with a statewide penetration rate. But I think that is completely dependent on the network feedback. So we don't really have a preference for either the census or the penetration rate methodology. So right now we've picked this one because it's kind of the easiest, and in some ways, keeping the model as simple as possible helps us with the CMS negotiation. So, in that sense, the preference is for the easiest one. But I mean, aside from that, we don't have a preference. So, if the network has one, we'd love that.
And I'm not looking at the timeline right now, but what's the timeline for us providing feedback? Yesterday, other than yesterday.
So I think that timeline is early August, but I will say, Simone, if I'm being really honest, what I think is going to happen with this is we're going to submit this model in August with what we have. I anticipate we're going to get feedback from CMS that will cause us to want and need to pull the model and make some tweaks and resubmit it in September, which is exactly what happened to us when we submitted the model for 2019. We submitted it early. We got tons of pushback and feedback. We pulled it and we resubmitted it. So I mean, that's really the reason why we're submitting it early. So I would say we should have as good and complete of a model as we can by August, because we want CMS's real feedback about our real model. But I anticipate that final decision we can make in September.
Okay. Thanks.
Are there any other questions before I pass it over to measures? Which is the one part, Steve, just so you know, Shannon and I didn't touch on it all in our one-on-one, so you'll get some fresh questions here today.
Great, thank you. So thank you, everybody. It's good to be here and good to see all of you. So yeah, I'm just going to touch on the value-based incentive payment percentage change, the new value-based payment measures, which we've been discussing in scoring and metrics, and then the enhanced HCBS FMAP quality incentive bonus. So I'll start with the first part, and again, I can see hands raised. So if there's any questions as I'm talking, go ahead and raise your hand and pose your question. So as far as the increase from 1% to 2%, we just want to continue to move towards value-based care as a system of care as a whole, and continue to align with other broader healthcare efforts throughout the state, and as it maps back to the all-payer model. So that is the rationale for this, as well as when we're submitting this next model, that this is something that we anticipate CMS looking favorably upon. So we really wanted to just continue to move incrementally in this direction, and this felt like a percent that was reasonable, but not too much of a potential pain for DAs as we continue to move through the different value-based payment measures that we've adopted. So Nicole, and I believe again that would start in calendar year 2023, correct? Okay. As far as the new
Correct.
value-based payment measures, thank you. So we've been discussing two different ones of adopting. One is the HEDIS measure, follow-up after hospitalization for mental illness, which is different than follow-up after emergency department visit for mental illness. And the two different measures that we're proposing is the percent of youth who received a follow-up visit within 7 days after discharge for an inpatient hospitalization for mental illness. And then, and that would be youth ages 6 to 17 years old. And then the other one is the percent of adults who received a follow-up visit within 7 days after discharge from inpatient hospitalization. And that would be age 18 and older. And these, the measurement specifications were taken directly from the HEDIS measurement specs that I was able to track down from NCQA. We had a lot of different discussions about attribution to a designated agency. So I'm going to share my screen. And this is information that I've shared with the Scoring and Metrics Committee. And I'm happy to send it out to this group afterwards in the meeting minutes as well, so everybody has a chance to review it. So again, this is the proposal that we have. And just as, you know, a refresh, this HEDIS measure has both a 7-day and a 30-day follow-up. Our proposal is just to go with the 7-day follow-up because that is what's happening with the all-payer model and the ACO as far as what they are tracking. So again, we're trying to just continue to align with the broader healthcare efforts across the state and these shared interest measures. So we would only be tracking the 7-day portion of this HEDIS measure. We'd be looking at primarily Medicaid beneficiaries, but we also wanted to account for those that are dual eligible. So, you know, older folks or other folks that maybe have Medicare, but again, they're dual eligible, so they have that Medicaid supplement as well. And as I mentioned, again, you know, we'd utilize the existing measurement specifications. Everything is very clearly spelled out as far as HCPC and CPT codes. And I would be happy to share those specifications as well. They're pretty prescribed and very detailed. But again, it's a lot to kind of comb through and think about, you know, as you're querying your EHR systems and how that might look. Just to be able to talk through those different processes. And, you know, some DAs, you might have it, you know, more nailed down than others as far as how to query those. So I think it would be incumbent upon the state to help facilitate some of those learning processes across the system, just to ensure that we have as much standardization as possible. As far as the timelines between pay for reporting and pay for performance, our proposal is to go with the first 2 years of a 5-year model being pay for reporting only. And again, this would be done through billing claims. So that's one nice thing about adopting this measure, is that it is not an extra added administrative reporting burden. It would just be, it would be calculated through your normal billing practices to Medicaid. And then the pay for performance, that would be the last 3 years, with the target being what the national benchmark is, because part of the rationale for moving to a validated, nationally recognized measure is we can benchmark ourselves as a state, but that also you are able to benchmark yourselves as an individual organization to see where we are at nationally. And again, I will send this out afterwards, because NCQA has all these different benchmarks annually reported out, so you can kind of see. And I will say there's been a downward trend in the national benchmark over the last however many years, which is not surprising for the Medicaid population, I think, just as the system continues to be stressed as a whole across the nation. So there was a request to have the measurement specifications put into this template that we've used for other value-based payment measures. So Eva put this together in this format. So yeah, I can happily go through this if you'd like, but again, I don't want to bore you with all all of this stuff. But I think the biggest thing as far as the attribution goes is, and whether, you know, how would it be determined whether a client was connected to an agency. So the proposal that we have is that there would be at least one case rate qualifying service within the 12 months prior to hospitalization. And we have these different codes listed out of what would be that, how that would be coded as a qualifying service. Sorry for the car sickness here, but I'll scroll down here. And we really have two different options. And one of them, option one, would be if it's coded to one of the allowable places of service listed here. So we have the codes over here and then the place of service code that would be allowable on this side. Or we could use, the option two would be using the different codes regardless of the place of service. So again, this just kind of clearly spells it out about how we would be doing that attribution piece, because that was something that has come up in discussion within scoring and metrics. Laura, go ahead.
Thank you. I'm just trying to figure out how to put my hand down.
No, no worries.
So if you're looking back for a year, so if somebody opened with us, had an intake, and then an intake draws down the case rate, and then never follows up again, and it was in that year, and they were hospitalized and discharged without us, any follow-up from us, would that person be in because they had a intake with us within 12 months but never followed through?
I think
Under
that's a
the
good,
strategy,
oh, go ahead.
like, go ahead. Under this methodology, yes.
Okay.
Go ahead, Matt. Matt, do you have your hand up? Oh, sorry. Is it Teams, Matt? Teams. If you want to.
Okay, I think I finally was able to unmute. So thank you for your patience there.
Yeah, no problem.
So I just also wanted to highlight, you know, I think we just reviewed this at outcomes meeting today, and I think there's consensus that we both see the value in this measure and realize that it's important. And I also want to note that the increased specificity you provided in the definition about attribution, we feel like is a really good step forward and will lead us to a place. There's still some remaining questions, but I think it's going to be something that will be amenable to both sides. And I want to also note that this being a DMH calculation, while you noted that's a really, you know, I think positive thing for reducing administrative burden to the DAs. It's also going to be critically important, though, that we're able to receive feedback and information and data back about our performance on this measure in the most timely fashion possible, so we can change our workflows and protocols to really meet whatever the target would be, especially given now the move from 1% to 2% where the stakes are higher. So I just wanted to keep that in the forefront of our conversations.
No, thank you for raising that. Yeah, and you know, I think part of the proposal is our commitment to do that scoring quarterly, as we're able to, you know, based off of the data that we receive, and be able to circle back with individual DAs to discuss it further, but then also provide, again, you know, looking at it from a quality improvement perspective, that technical assistance to assist with any sort of workflows and, like you said, you know, any policies or procedures that you might have internally, just again to help kind of move everything forward. And I think, again, you know, Matt and I had a brief conversation earlier today as well. And I think that, you know, Nicole, correct me if I'm wrong, but I don't know that we need to have this level of specificity or that level of granularity within the model submission. So we still have time, again, to get into those really fine details about attribution and specific codes. And, you know, and just make sure that, again, we're all on the same page about that. But yeah, Matt, I don't know if there's anything else you want to add as well.
Is there something that could be tested to see if that information, I didn't raise my hand.
Oh, no, it's okay, Laura.
To see if DMH can pull that data quickly? I mean, since it's your data, you could probably pull it now to see how easily it's done and give us some information before it even gets going, potentially.
No, Laura, I think that's a great suggestion, and yeah, absolutely. I mean, it's just to be honest, it's just a matter of us querying the MMIS, and then being able again to just do those calculations on our end and circle back. But given that we have enough time before this model would theoretically go into effect, I think there's definitely a learning curve for DMH as well, just to go through our internal process to, query the data on our end, calculate it out, report back out, and get that process more refined.
And then to give us an opportunity, I just think any test runs we can do before January would be great.
I totally agree. Thanks, Laura. Is there any other questions? Again, I know probably the broad majority of you maybe haven't seen this proposal yet in detail. So like I said, we'll send it out and have you be able to review it and ask any other further questions, because any questions that you ask help us, in my mind, refine things further. So they're greatly appreciated. The other measure, which we've discussed before, is the expansion of screeners down to age 12 and up. Our children's medical director had done some research in the research literature around the clinical, how should I put this, the clinical appropriateness of using some of these tools that we've used previously on this particular age group from age 12 to 17. And so what we had discussed in Scoring and Metrics for depression is being able to use and have essentially two options on the table that would be up to the individual clinician or designated agency as far as which screening tool would be most appropriate, and given the workflows, leave it up to the clinical discretion of the individual clinician. But for depression, it would be the PHQ-9 for adults, or the PHQ-A for adolescents. For substance use, it would be the CAGE-8 or the CRAFT. And then the last one for trauma was the PCPTSD-5. And that was the one that in the research literature, it was difficult to kind of discern which populations that screening tool had been normed and validated on. And from anything that we saw within studies that have been published, it was primarily veterans, typically men, and typically older. And when I say older, I mean like 65 years and older. So it wasn't necessarily clinically inappropriate to be, theoretically be using that on particularly age 12 to 17-year-olds, but we at least wanted to think about the option of utilizing a screening tool that would be more appropriate for that age group, and give that level of, or give that option for an individual clinician to make that call, depending on what the clinical situation is. And I don't have the tool pulled up in front of me, but I can share that out with you, that we had to go through and look at a few different options because it was hard to find a screening tool that was actually brief, and that could potentially fit into workflows and not add further time on top of any intake assessment that would be completed. So, and I apologize, I don't have it pulled up right in front of me. I should have done that before, but I'm happy to send that out as well. The one that we had identified is from the International Association for Trauma, and this was what they had recommended, and it has all the different measurement specifications. It has the tool itself, and off the top of my head, I believe it was like a 10 to 15 minute screen, depending on the level of conversation or discussion that might happen within that. So that's the other proposal as well. And again, I don't know that we necessarily have to have that level of specificity for our CMS model submission. So that's a conversation that we can continue to refine within Scoring and Metrics. and again, just to get feedback, as far as the potential impact on any processes related to clinical intakes. And
And the
then, oh, go ahead, Eva.
The only thing I would add to what you've said so far is that the for depression adult measure, as it's currently written, allows for a PHQ-2 or a PHQ-9, and the adolescent measure would continue that process. So you could do a PHQ-2 or 9 or A going forward.
Great, thanks, Eva. And then last is the enhanced HCBS FMAP quality bonus. So, and Nicole, correct me if I'm wrong, but again, we have it's essentially 971,000 that in funding that would be available for us to use for additional value-based payments up to 1%. And really focusing on trying to divert individuals from emergency departments and increase the system's ability to serve people more in the community. And so we were really trying to think about, what are some measures that we could look at that would get at this, get at that goal. So we were trying to focus on the percentage of crisis services and assessments that occur within emergency departments themselves. So we wanted to look at it and propose two different options. One would be similar to what we did with meaningful improvement and focusing on a 5% biannual decrease in the percentage of crisis services or assessments that occur in emergency departments, and doing a 3-year look back from MSR data. And then the second part is, knowing that some agencies are delivering services out in the community, as much as that are, clinically appropriate, because obviously some crisis calls, it is appropriate to see people in the emergency departments. But so again, similar to meaningful improvement, looking at that if agency is within that 90th percentile, which for CMS is the highest achievable benchmark of crisis services that are not delivered in an emergency department, and really again allowing for agencies that are really as they're able to deliver services out in the community, to reward those that are of the highest achievers. So we would again be looking at a similar scoring methodology that we had proposed for meaningful improvement utilizing MSR data. And this is written in the document, but the funds are available through March 31st of 2025. So we would have that time to expend those funds, or until the funds have been fully depleted, whichever would come first. So again, that was a proposal that we wanted to make to this group. And again, I think it would just help get at the issue that we're seeing as far as mobile crisis and, where those services are delivered. So, Carrie, go ahead.
Because I am in also the negotiation meetings, I'm getting a little confused. Can you please just clarify as far as actually negotiating the terms of these value-based thresholds, if you will? Is that the part of this group or the negotiating team or both?
Do you want me to answer that?
Yeah, if you don't mind, thank you.
This is here. This is where the feedback belongs here with this, because again, we think it's really important for you to provide feedback on the model as a whole, because that is how this model will be submitted. The provider negotiations tend to focus on single components. So this really is the place to provide that feedback on this model as a whole. The only thing I want to add to Steve said, because I just want to make sure it's clear to folks, is this $971,000 is new money, and it is in addition. So it's an additional 1% up to, and it was a part of a special request that DVHA made on how to use some of the enhanced FMAP funds that were coming into the state. And so that, you know, we will have those funds available until they are depleted. That might be until March of 2025. That is the final deadline. But it also could be sooner if the funds went out earlier. Carrie, were you going to say something else?
No, it just seems to me that this particular topic has come up quite a bit within the negotiation conversations. And so but I'm sure I can't see Simone and Julie. I'm sure that there's a way that we can handle the communication between that group and this group.
Yeah, I think it is a little fuzzy because a lot of the detail gets worked out, not even necessarily in this group, but almost in subgroups of this group. And then some of the negotiation takes place in the provider agreement, but we'll make sure that communication flows.
Yeah, it's interesting because we're now under pressure with the provider agreement to have it completed quickly, but it's going to take time for this discussion too. And I think I agree with the state. This is where it needs to fit into this model, and the provider agreement meetings, we can't go into this level of detail. So the timing is a challenge, and we'll just keep working with the department on that.
Yeah, and I appreciate that. I know, again, you know, with the approval of the 1115 waiver, provider negotiations, our submission to the CMS model, we're kind of at this perfect storm place of, you know, these different timelines, you know, and I know it puts a bunch of pressure under all of us. So, but again, I just want to highlight and continue to encourage questions to keep coming to Nicole, myself, or Shannon, because it just helps us continue to refine things more and get that level of detail just to ensure we're all on the same page. Matt, I didn't know, again, just giving your co-facilitation of scoring and metrics, if there's anything else you wanted to add, but just wanted to at least give you the opportunity.
Stephen, I think that was a good synopsis. Thank you.
Awesome. Thanks, Matt. So again, you know, if anybody does not have any questions right now, please feel free to reach out to me via email. We'll send all of this stuff out in the post meeting materials. And again, please follow up with any questions. Thanks.
Thank you. So I think, you know, what we tried to do is we did receive some questions that were submitted, and we did try to make sure to answer those questions in, you know, in the overview. But I do want to take a moment to see, you know, if anybody who had asked questions feels like there's things that still need to be answered, or if there are just other folks that have some questions that they want to ask right now. This is or if you just want to give us also like your initial reaction to this model as a whole, like what are your thoughts and feelings about it? Any of that I think is going to be helpful for us to kind of think through. I'm going to stop recording.